Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling burns. Burns is something I really love to teach about because it sounds like it's going to be pretty easy. It's the skin, like no big deal, but there's actually a lot of nitty-gritty things to get into, a lot of cool anatomy and physiology. So let's just jump right in. As always, we're going to start with our practice question. Save what you think the right answer is for the end, where we will circle back to the correct answer. So the nurse, you, is caring for a client with a major thermal burn. Which initial laboratory abnormalities does the nurse anticipate in response to the burn? Select all that apply. We have A, hemodilution, B, hyperkalemia, C, metabolic acidosis, D, hyperglycemia, or E, hemoconcentration. So when we talk about burns, we are talking about an injury where we have localized damage to the skin that escalates into or can escalate into a full body emergency. To really understand what's going on with burn clients, we have to think beyond just that localized wound. This is much more than a wound. When the skin, which don't forget is the body's largest organ and its best line of defense, is damaged, we get a major cascade of chaos. We break this down into phases. First, we start with the emergent phase. So we have an emergency first. That's where we go. And it's the first 1 to 2 days. So 24 to 48 hours after the injury, that's when we have the emergent phase. And what's happening physiologically is something called a capillary leak. Okay, basically, the burn has damaged the capillary walls of our cells and they become really porous. So imagine poking a bunch of holes into a water hose. The water, our blood, starts really leaking out of those holes. That's what we mean when the capillary walls become porous. They're leaky. And because they're leaky, plasma then starts to escape from the blood vessels and get into the surrounding tissues. This is what we call third spacing. Water's going out of the vessels into the tissues. Sodium leaves the intravascular space. That leads to hyponatremia. Water follows sodium. That leads to edema, water out in the tissues, without a lot of water in the blood vessels. So hypovolemia. And when we don't have enough fluid in our vessels, the blood is going to get thick and concentrated, hemoconcentration, which ultimately is going to leave the client at risk for hypovolemic shock. Low volume, low pressure, our blood pressure is going down. We can end up in hypovolemic shock. Now, with all of this chaos, the body is going to try and compensate. It's like, oh my gosh, my capillary walls are leaky. Fluid, sodium is all going out into the tissues. That's causing the edema. It's not leaving fluid in the vessels. My blood pressure is tanking. And the heart is like, oh my gosh, I need to do something. That's compensation. So the body will increase the heart rate in response to this falling blood pressure. Because low blood pressure, that's what's leading to our hypovolemic shock. That means we're not getting blood out to our organs. And really important is our kidneys. If we don't get good blood to our kidneys, we don't perfuse them, and they're not able to help clean our blood and produce urine. So one of the things us as the nurse has to look at really closely is what is our urine output. Anything less than 30 mLs an hour means the kidneys are not getting enough blood flow. Okay, so we've got leaky blood vessels, sodium and water going out into the tissues, causing edema, blood volume going down in the vessels, causing low pressure. That means not enough blood getting to the kidneys. So now we've got renal injury leading to low urine output. But in addition to this cascade of chaos caused by low volume due to the leaky capillaries, we also have major cell destruction. We've got this major injury to our tissues that has destroyed cells and therefore released a lot of extra potassium into the bloodstream. Remember, potassium likes to live inside our cells. Anytime we have massive cell damage and we break open those cells or lyse those cells, potassium gets into the bloodstream and we have hyperkalemia. What can that cause on our EKG? You know this, it's the tall peaked T waves, and that can progress into life-threatening arrhythmias if we don't do anything about it. So cells break, leak out potassium, hyperkalemia leads to tall peaked T waves. Now, we already talked about the kidneys being underperfused. They're not making urine. We maybe have less than that 30 mLs per hour. But another thing that happens when the kidneys don't get enough blood, they're underperfused, is that they can't recycle bicarbonate effectively. So, what is bicarb? B for bicarb, B for base. That's our buffer that's helping prevent acidosis. And when we can't recycle it efficiently, the body begins to accumulate acid. So basically, just remember kidneys, bicarb, don't have enough bicarb. That's our base. We become acidotic. So most of these clients on their labs will have a metabolic acidosis. And this is a lot of stress accumulating in the body. We've got metabolic acidosis, hyperkalemia, hyponatremia, or hypovolemic with a low blood pressure. Our heart rate's going up to compensate. What does all of this sound like? Fight or flight. Our sympathetic nervous system is totally freaking out. The adrenal glands are going to flood our system with catecholamines like epinephrine since we're in this fight or flight mode. And what does that do to our bodies? It triggers the liver to release glucose. Remember, the liver has stored up glucose for a rainy day in the form of glycogen. Well, the body's like, hey, it's a rainy day. We got a lot going on here. So all these catecholamines, stress, fight or flight, tell the liver we need this sugar. So we see a big bump in blood sugar, hyperglycemia. Now, I want to kind of recap because that was a lot of information and we are still in the first phase. This is still the emergent phase, first 1 to 2 days. Remember, it all starts because of our leaky capillaries. Sodium goes out, hyponatremia. Water follows sodium, hypovolemia. This is causing edema in the tissues, low volume in the blood vessels. That low volume leads to not perfusing the kidneys. So that's why we're watching urine output really close. Without our kidneys helping us up, we don't get that good bicarb. That's what leads to our acidosis, metabolic acidosis, okay? All of this is putting us in fight or flight. That's telling the liver, release glucose. We're getting that hyperglycemia. And because we have destroyed so many cells, we've lysed them open and released potassium into the blood. That's our hyperkalemia. A lot of lab abnormalities. That's where they're all coming from. So now we've summed that all up. Obviously, this is a big emergency. What are we going to do in this emergent phase? It is all about fluid resuscitation. Your number one priority as the nurse is to get volume pumped into this client so they aren't hypovolemic. Now, we do this in a really specific way. It is called the Parkland-Burn formula. And basically, we multiply 4 mLs times the percentage of what we call TBSA, which is their total body surface area that is burned, and that's in a percentage, times their weight, very importantly, in kilograms. So recap, what's that Parkland formula? 4 times TBSA times their weight in kilograms. And that gives us the total mLs of fluid that we are going to give in the first 24 hours of an emergent burn injury. Now, what fluid do we use? Most often, it is lactated ringers. We want an isotonic fluid that's going to go in the vessels and stay in the vessels. We need something to closely mimic the plasma and restore that circulating volume. We don't want any fluid shifting out into the tissues. That's already happening. Thank you, leaky capillary membranes causing edema. We don't need more of that. The other thing to make sure you know about this Parkland formula is that we get really aggressive with fluid resuscitation in the first 8 hours. So we did 4 times TBSA times weight in kilos. Let's say that gave us 8 liters. We're just pretending. 8 liters of fluid that we are going to have to give in the first 24 hours. We will do half of that. So in our example, 4 liters in the first 8 hours, and then we'll slow down a little and give the rest over the next 16 hours. So again, that's half of our Parkland burn formula fluid in the first 8 hours, the next half over the next 16, and most often we're using LR or lactated ringers. So all that's the emergent phase. Most of your test questions are going to be about that part of burn management. But obviously, that's only the first 1 to 2 days. More comes later. And we define that next phase, the acute phase, as when the capillary membrane permeability stabilizes. So when we've patched up those holes in the garden hose and we stop having a massive amount of leaking into the interstitial space. Usually that's at about 36 to 48 hours, so call it 2 days. The body starts to resorb some of that fluid, and our focus shifts from pumping them full of fluids to keep them alive to wound healing. We want to prevent infection, control their pain, give them really good nutrition because the body is burning a lot of calories and we need those calories to heal. So let's walk through a burn case together because lots of ins and outs, and there's tons of questions on tests and exams you can get here. So you're working in the ED. You've got a 32-year-old man that's rushed in after a kitchen fire. He has been cooking with oil, the pan ignited. He actually tried to carry it outside, but it splashed onto his right arm and up into his chest. Now he comes into you in the triage room. He is alert, anxious, in pain, and you go ahead and do an assessment of that burn. Let's see what it looks like. So his right arm is blistered, shiny, and moist. The surface is red and painful, but sensation is intact. The right side of his chest does look worse. We have a pale, leathery, and dry wound. And when you touch it, he doesn't flinch. No sensation over there. So before we go any further, we just described the burns. Let's pause and think about what depth or degree of burn we're looking at because we didn't talk about that yet. Remember, with burn degrees, we have first, second, third, fourth, and the higher the number, the deeper the burn. First degree is that surface layer. We're just in the epidermis, all the way down to fourth degree where we are seeing muscle and bone. So on the arm, what depth are we looking at? It's red, it's shiny, he still has sensation. That is a second degree or partial thickness burn. It's involving the epidermis and part of the dermis. But when we get to the chest, we had that pale, leathery, and no sensation burn. That is a third degree or full thickness where we have the burn extending through epidermis, dermis, and into subcutaneous tissue. All right, so we've got a mix of second degree on the arm, third degree on the chest. That is a major burn. And the next step that we need to do as part of our assessment is calculating the total body surface area burned. That's that TBSA that we talked about for the Parkland burn formula. And we calculate TBSA using the rule of nines, okay? The body's divided up into areas. You'll have to look at that chart to get the full picture, but we use the rule of nines in adults to estimate how much of that body is burned. So first, for the arms, each arm is a total of 9%. The front is 4.5, the back is 4.5, and we had the entire right arm burned, so that equals 9%. Then for the chest, we have the front of the chest being 9%, the back being 9%. And remember, the chest is different than the abdomen. That is also 9%. So abdomen and lower back, each of those are 9%. And then anterior chest, posterior chest, each of those are 9%. And this gentleman had his anterior chest burned, so that is another 9%. Full right arm, 9%, plus the anterior chest, 9%. That is a total TBSA of 18%. Now, because his burns are both partial and full thickness, that second and third degree, and they are greater than 15% TBSA, this is considered a major burn, and we are in that emergent phase of burn management. where the damaged capillaries are leaking plasma into the interstitial space. That third spacing causes the edema and the hypovolemia. The blood left inside his vessels is concentrated, it's thick and sludgy, that hemoconcentration. And we then get that poor perfusion. So we're damaging the kidneys, we're becoming acidotic, all that stuff that we don't want happening that we talked about. So, what are we going to do? We are going to fluid resuscitate. In that emergent phase, we got to get fluid into those vessels to get that blood pressure up. So, we're going to use our Parkland burn formula: 4 mLs times our TBSA times our weight in kilos. So, we just calculated 18 for our TBSA. And let's go ahead and say that this client is 70 kilos. The Parkland formula is going to be 4 mLs times that 18% TBSA that we got from the rule of nines times 70 kilos, our client's weight in kilos. So simple multiplication problem, 4 times 18 times 70, that gives us 5,040 mLs. Remember, this is the total mLs we're going to give our client in 24 hours, and usually it is lactated ringers or LR. Also, don't forget, we're going to give half of that, 2,520 mLs, over the first 8 hours, because we're going to get really aggressive to try and combat that hypovolemia and keep good perfusion out to all the organs, but especially the kidneys. So 2,520 mLs of LR, we're going to give that in 8 hours, and then another 2,520 mLs over the next 16 hours. Now, I want you to pause really quick. What's our goal? What are we trying to do? Why are we giving over 5 liters of fluid, so much fluid? We're being really aggressive here. Because we're trying to restore circulating volume. We want to prevent shock. We do not want hypovolemic shock. And the capillaries are leaking fluid because they are damaged by this burn. So fluid replacement keeps perfusion to our vital organs. Speaking of the kidneys, that's going to be our next critical piece of this puzzle. You as the nurse have got to be monitoring urine output, which means you're inserting a Foley and you're looking for about 0.5 to 1 mils per kg per hour of urine output. The gold standard goal is like if you don't get 30 mLs out in an hour, the kidneys are not getting enough blood. Or if you've been getting, 60, and then all of a sudden it drops to 30, a drop in urine output is a red flag. The kidneys are not getting enough blood, and we could suffer an AKI from poor perfusion related to a burn. So we don't want to let that happen. We're also going to be getting a ton of labs. Remember in the beginning, we said hyperkalemia because those cells are lysed open, releasing potassium. Metabolic acidosis because our kidneys can't recycle that bicarb. We don't got enough bicarb or base. We become acidotic. Our blood gets really concentrated. The H&H can even get elevated due to that hemoconcentration. We're in fight or flight, so our liver is releasing glucose. That's our stress response causing hyperglycemia. Labs are all over the place. So we're going to be doing lots of checks as we seek to correct this. But what we're doing is giving fluid. What do we want to see as we are giving that fluid? We want urine output stabilizing. A big one, we want heart rate slowing down while blood pressure comes up. That's telling us our body's getting out of fight or flight mode. The fluid we're giving is getting that blood pressure up. The capillary membrane is becoming restored. It's not leaking as much. And with that blood pressure up, the body doesn't have to compensate and elevate the heart rate. We also want to see those labs starting to normalize, potassium coming down, fluids diluting out that hemoconcentration, so that H&H that was artificially up coming down, and perfusion improving. That's when we move into that second phase, that acute phase. The capillary leak closes up, fluids no longer shifting into the interstitial space, and we can focus on healing. First phase, emergent, we are fluid resuscitating. Second phase, acute, we're managing pain, preventing infection, caring for wounds, and really trying to promote healing. And this is going to take weeks to months, even to years with really serious full body burns. So these are things like skin grafts, healing of wounds, physical therapy, restoring range of motion, all of that really important long-term things. But the big takeaway I want for you when you're thinking about these questions on your exams is never forget that burns are a systemic injury. Okay, damaged skin, yeah, it's on the surface, but it sets off a domino effect, all due to that leaky capillary membrane. Your intervention is all about fluid resuscitation so that we keep that blood pressure up and perfuse our organs while the capillary membrane heals. And with that being said, I'm going to circle us back to our practice question because hopefully now you'll know the right answer and why. So again, the nurse is caring for a client with a major thermal burn. Which initial laboratory abnormalities does the nurse anticipate in response to the burn? Select all that apply. We have A, hemodilution, B, hyperkalemia, C, metabolic acidosis, D, hyperglycemia, and E, hemoconcentration. What do we think? Go through A, B, C, D, E. It's a select all that apply. So yell it out one at a time. A, will we have hemodilution? No, absolutely not. That blood is going to get concentrated, which is choice E. Little test taking tip here. Opposites can't attract. When you saw A and E, hemodilution and hemoconcentration, you should have immediately known that those can both not be true at the same time. Is the blood diluted or concentrated? It's concentrated because fluid is leaking out into the third space. A is wrong. E is correct. What about B? Will we have hyperkalemia? You bet those cells are going to lyse, open up, and dump potassium into the blood. What can that lead to? Tall, peaked T waves. C, metabolic acidosis. Correct or incorrect? Correct. A burn client will become acidotic because the kidneys can't recycle that bicarb. Not enough bicarb, not enough base. We become acidotic. C is correct. And last answer choice we had was D. Will we see hyperglycemia? Yes, correct. You bet. We are in fight or flight. The liver is going to release that glucose to help us fight. So in fact, B, C, D, and E, all correct. We're hyperkalemic, acidotic, hyperglycemic, and our blood is hemoconcentrated. That's a lot going on. So if I leave you with one thing, remember, after a major burn, you're going to see a lot of changes. And they all reflect the fact that capillary membrane became really permeable and fluid leaked out into the tissues, that interstitial space. Your priority is fluid resuscitation. So know how to calculate TBSA, know your Parkland burn formula, and know that your number one priority is fluids. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.